As we've been seeing over the past few days, I mean, we have been doing more and more, and our stent grafts themselves have improved in their design. Our intraoperative imaging has improved. Our technical skills have improved as well. And secondary to that, we've been taking on more and more difficult cases. And what has tended to happen, what started off with just plain simple infrarenal AAAs, we've been starting to take on more proximal pathology and more proximal disease all the way up to the arch. And that is not without consequence. The main pitfall with endovascular repair has always been the reintervention procedures with very high reintervention rates. But if we look at it a little bit closer, we're going to see that, in fact, most of these reinterventions actually are minor catheter-based interventions that are associated with low mortality. And because of that, again, we have been pushing things further, and a lot of cases are being done outside of IFU on that basis. And we're taking on cases with difficult iliac access. We're taking on cases with angulation in the neck and with short necks. With that, you start to wonder, the more we do, you would assume that the reintervention rates would start to go down. The main issue here is because we're doing more and more complex cases, the reintervention rates have not gone down significantly. And in fact, what we're starting to see is a lot of the cases are, after exhausting our endovascular reinterventions, the only solution we have would be an open conversion or a late open conversion. Most of late open conversions would be related to endoleaks, but also obviously due to graft migration, sac expansion, as well as graft infection and ruptures. But looking at it a little bit closer, we're going to see that if we look at our IFU adherence, cases that had reintervention, the IFU adherence was just around 44%. Compared to a 79% adherence to IFU in uncomplicated EVARs. Recently, with the current controversial issue with the NICE guidelines, the question here is, do we really need strong NICE guidelines? I think we do. I mean, we are pushing the envelope for quite far. 60% of treated AAAs have anatomy that falls outside of IFU. And if we take a little bit more liberal approach, you'll also say about 30% still will sit outside IFU. But the problem here is that the draft guidelines, rather than starting to give us an idea as to when and where we should or shouldn't be doing EVARs and in which cases, it's taken a blanket kind of no EVAR in elective aortas whatsoever. So for people with unruptured AAAs, offer open surgical repair. And if open surgical repair, yes, absolutely, do not even offer an EVAR. And don't offer EVAR even if open surgical repair is not even suitable. So basically, do not do an elective EVAR. And regarding complex cases, which you could argue, are we talking about outside of IFU infrarenals, or are we talking about FEVARs and BVARs? They shouldn't be done except within an RCT. And the rationale behind that has always come down to the more long-term complications, and that these complications mean that people will need further procedures, i.e. re-interventions. And the main issue has been cost, that even if long-term benefits were achievable, they couldn't plausibly be sufficient to outweigh these costs. So that has let us kind of go back and look at even our own results where we needed to do our re-interventions post-EVARs, and especially looking at open conversions following EVARs. And what we mean by a late open intervention is an open surgical procedure performed more than 30 days after the initial EVAR procedure. So I'm not talking about intraoperative conversions. And we try as hard as we can to preserve the endograft, especially in cases of type 2 endoleak with sac expansion, where an endovascular approach has failed, where we would ligate the lumbars and occasionally the IMA. And in these cases, we don't necessarily need to clamp the aorta at all. However, that's not always feasible in 100% of cases, and there are cases, especially with graft infection or with type 1A endoleaks, where we would need to explant the EVAR. Either a full explantation, or occasionally, if the suprarenal fixation doesn't come out, we would sometimes leave the suprarenal fixation component and sew the Dacron graft into that. So over 1,000 aortic procedures, if we exclude our emergency procedures and thoracoabdominals, that leaves us with just under 700 infrarenal straightforward EVARs, where from those 12 required a late open intervention. And you can see here the indications for the late intervention. Between the majority of them were endoleaks, as well as an aortoenteric and an aortocaval fistula, a strength fracture, and one case with a retrograde type B aortic dissection, which due to the friable nature of the proximal aorta, we actually needed to do a quadrifurcated graft bypass back to the visceral vessels. The majority of the patients were hypertensive males. And if we look at the breakdown of the devices that we used, and looking at overall re-interventions, including the endovascular re-interventions, a total of 7.7 endovascular re-interventions were performed, with no particular difference dependent on which particular device that we've used. And looking then at the open interventions, late open convergence, again, there was no particular difference regarding the initial device that was used. A total of 5 graft preserving procedures were performed, with 7 explantations across the board of the different devices. The mean interval between the initial EVAR and the open re-intervention was roughly about 50 months. 50% of those patients had already had prior endovascular interventions. The mean size of the aneurysm at the time of conversion was 7.2 centimeters, with a mean blood loss of just under 3 liters per procedure. The 30-day morbidity was 14%, and 30-day mortality was 14% as well. Again, when we looked closer at those procedures that were done within and outside of IFU, looking at those who did undergo a late open conversion, 50% of them were done outside of IFU, compared to 37% of those who did not require any further re-intervention. And similarly, when it came to the endovascular re-interventions, 47% versus 38%. So yes, it's not statistically significant, but there definitely is a trend in favor of working within IFUs, within the infrarenal AAAs. So yes, the average consensus is that the open late re-interventions is somewhere between 0% and 2%, with some series reporting up to 9%. Our results are about 1.7%. Mortality post these procedures is reported to be about 24% within the Eurostar registry. Now, the main issue here is with the guidelines that they're recommending against complex EVARs and basically recommending against EVARs full stop, due to the same issues we have alluded to earlier. But rather than abandoning EVARs altogether, I'm just wondering, is it time to start thinking of just specify, or at least limit to working within IFU where there is a possibility of better outcomes, as opposed to a blanket ban on elective EVAR in EVAR AAAs, mainly due to the implications that will have on ruptured aneurysms as well. Thank you.
Thank you very much. Very good. Any questions?